Good morning, everybody. Thank you for joining us on this update on treatment of axial spondyloarthritis at the Room Now Live 2021 event. It's a pleasure to be here, and we'll share some updates mostly from the last couple of years, but I also have a few introductory slides to set the stage. These are my disclosures. So the goals of this lecture are primarily to understand the treatment principles of axial SpA. Hopefully, you'll be able to recognize that there is a window of opportunity in the treatment of axial SpA, and I will touch upon the most recent advances, as I mentioned earlier. So we'll start off with the ACR 2019 update of treatment of axial spondyloarthritis. So both pharmacological and non-pharmacological treatment options are recommended. In non-pharmacological options, you have physiotherapy, home exercise, group exercises, and all of them are recommended for ankylosing spondylitis. In pharmacological management, you start off with Nsaids, and if Nsaids are not effective, in some parts of the world, people do try DMARDs. However, DMARDs are not recommended for axial symptoms. So after Nsaid failure, you have to go to biologics, and currently we have two TNF inhibitors and IL-17 inhibitors approved for the treatment of axial SpA in North America. Other medications, including biologics like IL-6 inhibitors, IL-12/23 inhibitors, IL-23 inhibition, abatacept, rituximab, and other medications like pamidronate and apremilast have been tried, but unfortunately they don't work for axial symptoms. We do have other options coming up, especially the JAK inhibitors, maybe very soon in the market in North America for axial SpA. We also have combined inhibition of IL-17A and F with bimekizumab that may come up soon. As I mentioned about DMARDs, methotrexate, sulfasalazine, leflunomide, all of these agents may be used if there is significant peripheral arthritis. And ustekinumab and risankizumab are both effective for psoriatic arthritis and psoriasis, and as I mentioned, not for axial spondyloarthritis. This is the only slide I have on psoriatic arthritis treatment because in the interest of time and the amount of new information available on axial SpA, I've concentrated mostly on axial SpA. So for psoriatic arthritis, this is an excellent slide, although it needs updating, and I believe the update is coming very soon in a few months. This is the GRAPPA treatment recommendations that came out in 2015, and then hopefully 2021 we'll see the most latest update. You can see the treatment is recommended based on domains and depending on primarily whether it's peripheral arthritis, axial disease, enthesitis, dactylitis, skin involvement or nail involvement. The treatment options available here are different. And you can see that most modalities and most predominant domains require biologic treatment. And here you see the DMARD used significantly for peripheral arthritis. You can also see Nsaid use for axial disease. And the biologics primarily used here are TNF inhibitors. You can see IL-17 inhibitors being used, and you know that IL-23 inhibitors and IL-12/23 inhibitor as well as JAK inhibitors are also used for management of psoriatic arthritis. So coming back to axial SpA, as I mentioned, we should not be missing the boat in the treatment of axial SpA, because early diagnosis means early initiation of treatment, and early initiation of treatment results in higher chances of treatment response, higher chances of potentially achieving drug-free remission, and also higher chances of slowing the progression of this disease. Here is an example of TNF inhibitor use based on the disease duration and what the impact is. Here you have the major studies of TNF inhibitors that came out initially, and you can see that the treatment response here is around ASAS 20. That's a 20% improvement in symptoms, between 50 and 60% at 24 weeks of treatment. Now, patients included in these studies had an average disease duration of around 10 to 15 years, so quite well-established disease and quite late in starting treatment. And that's why the 20% response, or ASAS 20, is only 50 to 60 at 6 months. Now let's compare that to this result, which is just an example of the more recent studies where patients have been included at much earlier stages. So here you have patients who are at much earlier stage within 5 years of disease and have evidence of active inflammation. And just look at the third column, partial remission. You see similar numbers of 50 to 60% partial remission within 16 weeks. So that's the kind of difference that you expect when you start treating patients early, as opposed to the much lower responses in delayed treatment. Another part of disease modification is disease modification, and you'll see here an example where syndesmophytes are formed. At baseline, there is minimal syndesmophyte formation, but over a period of this is over a period of 4 years, and you can see significant progression. In fact, this is not very common. Such rapid rates of progression is not very common, but they do occur in a handful of patients. The first treatment modality that was tested for preventing this kind of a progression was Nsaids. And the first randomized control trial that was quite promising when it came out at that time was on celecoxib. And as you can see here, the patients who were given celecoxib on demand at the end of 2 years had much higher progression compared to patients who took it on a regular basis. However, on post-hoc analysis, the actual difference in the amount of celecoxib that these patients took was much lower. Only a 42 milligram mean daily dose difference was there. So how much of this is really biological effect was not known at that time. So further studies were done. Here is an example, the ENRADA study, where diclofenac continuous treatment was compared to on-demand group, and X-rays was taken at baseline and at 2 years of follow-up. Around 80 to 85 patients in each group, around 60 patients completed the trial in each group. So here are the results. What you actually see here is the blue dots are the patients who took continuous diclofenac. So in fact, although there was no significant difference, if at all, there was slightly more progression in that group. So after this study, it has been the understanding in the clinical world that the TNF inhibitors are very good for control of disease. But if patients are very well controlled on disease, you don't need to add on Nsaids for just preventing progression. So Nsaids need to be used only for an as-needed basis. This is a more recent study on Nsaids and radiographic progression, and this came out of the SpA cohort. And you can see here, it was in the full spectrum of axial SpA with around 123 radiographic axial SpA and 143 non-radiographic axial SpA patients included. Non-selective COX-2 inhibitors were around 52% out of the 67% who were on Nsaids, and a smaller percentage were on selective COX-2 inhibitors. You'll see here the results, they're quite interesting. The lowest amount of size change was seen in selective COX-2 inhibitor group, and the highest was seen in non-selective COX-2 inhibitor group. So if you look at the statistical significance, there was a difference between the two. Now, however, there was no significant difference when you compare the selective COX-2 inhibitors to no Nsaids. So this is really what we need to do to see that. That's why I said the results are interesting. So this was a fairly large observational study in an inception cohort. However, as I mentioned, Nsaids versus no Nsaids were not significant. So I would say that these results should not really change our clinical approach that I mentioned earlier. I'll come to a case, a 40-year-old female. She was diagnosed with axial SpA based on bilateral grade 3 sacroiliitis, long-standing inflammatory back pain. She also has evidence of syndesmophytes in the L4 upper vertebral corner and evidence of inflammation as shown by higher ESR and CRP levels. Now, the question is, what are the chances of progression in this person? And is there an advantage if we treat with biologics? Okay, so to answer the question on whether there or the risk of progression, as you can see here, this is the cumulative probability plot on all our patients in the cohort, and you'll see that only around 60% of patients have no progression, while 20% have significant progression. So how do we identify those 20% who have significant progression? And what we found was that the most important predictors are damage existing at baseline, presence of inflammation at baseline, and smoking. And smoking is interesting. Smoking is not just whether they smoke or not, but the amount they smoke is also important. And as you can see here, the highest rate of progression was seen in those who had more than 10-pack-year history. Okay, coming on to the impact of biologics. This was the first study that showed that TNF inhibitors can indeed reduce the rate of progression. You can see here the predictors of progression: baseline damage, baseline ESR, smoking, and the use of TNF inhibitors. In this regression analysis, TNF inhibitor use was associated with the 50% decreased odds of progression. Multiple different ways of analysis were done. You can see here multivariable analysis with all variables still significant, and you can see here multivariable analysis with only the significant variables in the primary analysis included. Again, TNF inhibitor use associated with more than 50% decreased odds of progression. Since this study was published, many other studies from different cohorts have been published, and more or less it's now quite well understood that TNF inhibitor use, especially when used early, can lead to a decreased risk of progression. And here the window of opportunity, just to show you that, I'll show you the slide. This is data from patients who started TNF inhibitors within the first 5 years, 5 to 10 years, or more than 10 years after disease onset. And you can see here that the lowest rate of progression were in patients who started the drug at less than 5 years of symptom duration. Okay, this is an interesting study on anti-TNF use and PET MRI scans to look at osteoblastic activity. Around 16 patients were included, 11 male and 5 females, with active radiographic axial SpA who had failed Nsaids. And you can see here 3 tests of MRI with 18 F-PET MRI were done. The SIJ MRIs were available for 16 patients and spine MRI for 10 patients at baseline and after treatment. Okay, and the scoring was done based on quadrants. You can see 4 quadrants on each side. The discovertible units were also scored for all the available the parameters that are showed here, especially bone marrow edema, but also for structural lesions. And then what you see here is the results. You can see the bone marrow edema significantly improved with treatment, but interestingly, the PET signal also improved, showing decreased osteoblastic activity. You can also see a significant improvement even in fat erosions and sclerosis in these patients. As expected, ankylosis was not that much of a difference. Okay, so within 4 months of TNF inhibitor treatment, there was a significant decrease in osteoblastic activity, which is corroborating our clinical studies. Bone marrow edema improved, and also structural lesions improved. So likely the disease-modifying potential starts on early itself, but to actually see it with X-rays, you need to wait for a significant amount of time, because X-ray evidence of progression is very, very slow. And this is the last study, which again is just published on TNF inhibitors and spinal radiographic progression. This is based on the Alberta follow-up research cohort, the forecast cohort, and 427 radiographic axial SpA patients were included who had at least 2 X-rays to assess progression. Here, interestingly, what they've done is they've looked at the odds of progression at the end of 2 years if at baseline there was use of TNF inhibitors, and they've compared it to a lack of TNF inhibitor use. So instead of doing a matched cohort study, they've done more of a GE model looking at presence of TNF inhibitors and chance of progression. And you can see here that MSAS change, as well as when you look at it categorically as progressors based on MSAS more than 0 or MSAS change more than 2, or presence of new syndesmophytes, there was a significant decreased chance of progression, decreased odds of progression here. In sensitivity analysis, you can also look at the different models where presence of TNF inhibitors between visits, the duration of TNF inhibitor use, as well as continuous TNF inhibitor use of more than 4 years versus less than 4 years. All of these significantly decreased the risk of progression. So again, adding to the mounting proof that TNF inhibitors do have disease-modifying potential. How about IL-17 inhibitors and disease modification? We don't have a lot of studies looking at IL-17 inhibitors and disease modification. This was one study where the 2-year clinical trial data of secukinumab was compared to an Nsaids RCT, the previous RCT that I introduced to you, the ENRADA study. And what essentially was done is the measure 1 progression in the measure 1 data was compared to the ENRADA's data. And you can see here the change in Nsaids will appear to be lower in the measure 1 data set, but likely because of lack of power, it was not statistically significant. So there seems to be a trend where IL-17 inhibitors as well have the same kind of effect that we saw with TNF inhibitors, but we have to wait to see final proof of this in larger and longer studies. Okay, how about studies on non-radiographic axial SpA? We all know that the treatment response is similar in AS patients and non-radiographic axial SpA patients. You can see here as an example from the certolizumab study where both AS and non-radiographic axial SpA patients are included. You can see the ASAS40 responses and AS patients, non-radiographic axial SpA patients, almost similar responses. Now, what is recent is there is now evidence for IL-17 inhibitor use in non-radiographic axial SpA. This is the first study I will show you. Secukinumab 150 milligrams improved signs and symptoms of non-radiographic axial SpA. This was a phase 3 double-blind study. This was the study design where loading secukinumab was compared to secukinumab without loading and placebo. Up to 1 TNF inhibitor failure was permitted, and patients were followed over a period of 52 weeks on placebo or the drug to look at the primary endpoint. Okay, so you will see here that patients had either MRI positivity around 42% or just CRP positive around 27% or both positive around 30%. Okay, and only around 10% had used one TNF inhibitor in the past. Straight away going to the results, you'll see the significant improvement in symptoms with an ASAS40 at 16 weeks of around 42. No significant difference at 16 weeks when you compare loading versus no loading. But early on, there appears to be an advantage of loading for achieving these responses at much earlier time points. But by 16 weeks, there doesn't seem to be a difference there. And you can look at long-term effect results at week 52. You'll see here that the patients continue to respond at 52 weeks of treatment. This is the second study. This was ixekizumab, the other IL-17 inhibitor currently available. And this again was a phase 3 trial. It's again a 52-week placebo-controlled trial. And switch to open label was permitted at week 16. Here you see the 2 doses were studied, ixekizumab every 2 weeks or every 4 weeks compared to placebo. Around 300 patients were randomized to approximately 100 patients per group. The primary endpoint here, as you see here, the primary endpoint was at 16 weeks. There was also a dual primary endpoint at 52 weeks as well. You can see the ASAS40 response at week 16 was significantly different compared to placebo, with not much of a significant difference between the 2 dosing regimens. And at 52 weeks as well, it was significantly different compared to placebo. So the next question is, can we withdraw treatment in non-radiographic axial SpA? Okay, this is the Ability 3 study. Very briefly, I'll go through these slides very quickly in the interest of time. So patients were included in the study and given open label adalimumab. If sustained remission was achieved at week 28, they were either asked to continue adalimumab or completely withdraw adalimumab. And we all know the results. Around 305 patients entered the study for the randomized phase. And you can see here a significant drop-off when patients stopped adalimumab. So this study almost showed that a flare is almost inevitable in a significant chunk of patients who stop biologics. So maybe stopping biologics abruptly is not a good idea. But how could we taper the dose of biologics in axial SpA in general? And this study was, this question was answered in this certolizumab dose reduction study. So again, similar to the previous study, open label induction phase by week 48, then patients were randomized into either continuing full dose or half the dose of certolizumab or continuing in placebo, which would be equivalent to completely stopping. And around 60 patients completed the open label, of which 323 achieved sustained remission, which is a good number, and they entered the randomized double-blind phase. And you can see here, if you stop treatment, the placebo group, significant drop-off, while not much of a difference in continuing versus just reducing the dose. And there was no difference whether patients had radiographic or non-radiographic axial SpA. Similar results were seen. So clearly, dose reduction is feasible in axial SpA. Okay, coming on to the next case here, we have a 46-year-old female who has ankylosing spondylitis with bilateral grade 3 sacroiliitis, B27 negative, but high BASTI and already failed etanercept, infliximab, and secukinumab. So limited options are an issue with axial SpA treatment. Unlike in rheumatoid arthritis and even for PSA, there are many more options compared to axial SpA. But hopefully not for long, because we have new drugs coming into the market. This is a study of upadacitinib, the Select Axis 1 study. You can see this is the design of the study. There was a 14-week placebo-controlled phase of 15 milligram upadacitinib compared to placebo, and followed by open label extension up to week 104, the primary endpoint being ASAS-40 response. Around 90 patients in each arm were included. You can see the study characteristics of the patients. The B27 positivity was around 75 to 80%, and duration of symptoms was again quite long at around 14 to 15 years. Here are the results. At the primary endpoint, ASAS-40 at week 14, significantly higher, almost double in the upadacitinib group compared to the placebo group, and treatment response is sustained. In fact, it looks like almost like there is continuous improvement even beyond week 24 to up to week 64. And you can see that more clearly in the partial remission as well as inactive disease data. There appears to be, even beyond 24 weeks, there appears to be additive improvement over subsequent weeks with continued treatment right up to 52 to 64 weeks. Okay, and to complete the story, MRI evidence of inflammation as well significantly improves with the treatment of with upadacitinib. This is a second JAK inhibitor, the tofacitinib, for the treatment of AS, again a phase 3 randomized double-blind study, a similar kind of a design where double-blind phase up to week 16. The primary endpoint here is ASAS-20, followed by open-label phase up to week 48 here. And you have around more than 130 patients in each arm were included. Basic demographics of the patients, you see B27 was higher here, around 83 to 85%, and you can see here the duration of AS symptoms again was very high at around 12 to 15 years here. Okay, results. Again here almost double the amount of ASAS-20 response, primary endpoint at week 16. Week 16 can be seen here. You can also see the other parameters here, change in ASTAS, change in high sensitivity CRP, change in the fatigue scores, all were significant in the tofacitinib group. So we can summarize all of the lessons from today. Definitely the paradigm of axial SpA management has changed. There is an emphasis on early diagnosis. There is a window of opportunity in the treatment of AS. We know that biologic treatment can help reduce the rate of progression. Dose reduction in axial SpA appears to be feasible as opposed to completely and abruptly stopping treatment. Different modalities of treatment beyond the Nsaids and TNF inhibitors are available, especially the new data on IL-17 inhibitors and non-radiographic axial SpA extends the use of this medication to the full spectrum of axial SpA, and the new drugs that are likely going to be in the market soon, JAK inhibitors. So thank you very much for listening, and this is the team that I'm fortunate to be working with, and I'm happy to answer any questions if you have.